Good afternoon, everyone. Let me share my screen. Like I said, good afternoon, everybody. Sorry about the little momentary glitch there. As Julia had mentioned, I am an infection control nurse with the HAI-AR prevention program. I've been with the program since 2018, and I'm going to kind of change things up. If anybody's seen like a presentation I've done before, usually I talk about cases that are going on in the state, trends on different things, and things to be on the lookout. I wanted to change it up a little bit and talk about some of the things we've been having ever since COVID. We've been having a lot of conversations behind the scene about how we can try and make not only our lives simpler, here at the state in the HEI program, but also all the IPs out there in the field's lives a little bit easier. And so we're going to cover topics on things that this is a direction we're going. We don't have anything finalized. So I have an ask of everybody. Could you please, I'm going to have my contact information at the end. We want your feedback on as we start like kind of bringing this out or ideas that basically you might have. If you wouldn't mind just simply just sharing it, we'd greatly appreciate it. So let's go to what are we going to talk about? So essentially, one of the things we want to try and do is like I said, I want to make you guys' lives a little bit easier. We're going to streamline the reporting process, make it a little bit easier, and move it into workflows that you guys may already have in place at your facilities. We want to cut down on some of the administrative burden that you might experience, and more importantly, provide you guys with more timely and relevant feedback basically from this on trends going on in the area and also at your facility. Okay. We also want to basically describe about like how we can more accurately and efficiently use this information. You guys send us all this information. We want to make sure you're getting something that is really meaningful back in a timely fashion so you can actually use this to help protect our patients that we all serve. We want to collaborate with you guys basically to make this process more meaningful to you. Before I get into the details of some of that, and I apologize for saying that, I also want to provide a couple of updates to our programs. These have been coming on over the last several months or even over the last year. I haven't made a presentation to basically the boot camp in a little bit, so I did want to highlight a couple of things. So let's get right into that. The first thing is that I wanted to talk about basically our antimicrobial stewardship efforts. For folks that are not familiar, Dr. Pillai is now our antimicrobial stewardship lead. A lot of folks are very familiar with Dr. Spicer when he was with our program, and he was our lead for a number of years. Unfortunately, he basically had to leave our program a little while ago. And so Dr. Ply has actually been working with antibiotic use data since 2022 and officially basically took over the reins of antibiotic stewardship back in 2023. So here's his contact information. I also want to let you know that there's some exciting news. If folks have not seen it yet, we also have a new web page. Basically, if you go to the KDPH website, if you go on the left-hand side of the screen, you'll see a series of tabs if you want to get to specific programs or specific things here at the Kentucky Department for Public Health. Well, now we have a new tab for antimicrobial resistance and stewardship. And the group that basically had helped to roll that out are really, really excited for folks to be able to go to that, get some information off there, and everything that is about antibiotic stewardship, it's available to you there as far as all the programs we've got going on. I will not even attempt, because Dr. Ply is a whole lot better at explaining some of the stuff that they do than I am. So I will not even attempt. I don't even want to screw up the whole message of it. So I'm going to let you guys go there and basically take a look and find the information for yourself. And if necessary, reach out to Dr. Ply for any questions you might have. Okay, so that's one big update. The other thing is, we've got a new NHSN program lead, if folks didn't already know. A lot of you had worked really closely with Clay Bryant before he had left our program to basically go work with, he's now contracted with the CDC. And he was very helpful to a lot of programs across the state. Well, like I said, unfortunately for us, fortunately for him, he had a great opportunity that was made available, and he basically jumped and took it. And so around mid-January, we actually brought Cody Roca on board. And Cody actually comes to us from the state of Tennessee Department of Health, and he did a bunch of analysis of NHSN data there. He also did some rural health work, and by that I mean he did like analysis and outreach in that regards. And I'm quoting him directly. He said that he did all things CRS. So if folks have gotten a phone call from me here in Kentucky, he would have been my counterpart when it comes to CRS in Tennessee at that time. And he also spent a lot of time basically on outbreak responses. We're still trying to basically add some additional things and basically get some of the experience that he's had and be able to use that here within the state. But one of the things is he's now our new NHSN program lead for our program. And so here's his contact information. Please make available and reach out to him if you guys have any questions when it comes to NHSN. So those are the two big updates that I wanted to make sure that I basically shared with you guys. And let's kind of get into some of the other things that I wanted to basically share with you today and have a big, robust discussion on. And so one of the things is, and I know I'm kind of preaching to the choir, so I just bear your patience here for just a second. And one of the things that we're seeing is, as far as like MDROs and their impact here in Kentucky, it continues to be a problem here in the state of Kentucky, just like anywhere else in the country. The number of reports that we are receiving is growing and demonstrating a lot of antibiotic resistance. And it makes it harder to treat infections, obviously increases the risk of death. It also contributes to longer health stays and to healthcare costs. And so it becomes a major complication for patients basically who have these particular pathogens identified in either a clinical or a surveillance screening test. As we all know, that there's an issue with MDROs in nursing homes as well. And the problem is that they can spread very easily in nursing homes, and treating them is not, because of the unique setting that skilled nursing facilities and long-term care facilities pose. It's not the easiest to be able to treat those and still basically provide the kind of care and maintain a sense of home for the folks that basically are residents of these facilities. It's a very difficult challenge. And so, and then the last thing is that obviously being able to identify these early and be able to take the appropriate prevention steps is really key to limiting the spread. So, you know, what are we doing to kind of help make this work for us as opposed to work against what we're trying to do as far as caring for patients here in the Commonwealth? So obviously, you know, there's a lot of, when these organisms are identified, we want to basically implement strict infection control practices such as hand hygiene, contact precautions, and of course, environmental disinfection. And we all know that basically antibiotic use is a contributor to the increased incidence of antibiotic resistance. And so that's another reason why I basically had mentioned our antibiotic stewardship lead, Dr. Pillai. But I also want to point out that basically please make use of an organization, the Kentucky Antimicrobial Stewardship Innovation Consortium, or KASIC. There are a lot of programs out there that are available to help basically for all of us to make sure that we're appropriately using at the right times and the right doses and the right amounts and the right medication to basically treat some of these infections. In addition, basically a number of years ago, enhanced barrier precautions had rolled out, and that was back in 2019, if my memory serves correct. But then also a number of years later, CMS basically rolled it out as basically that was one of the recommendations for practice basically within skilled nursing facilities is to implement appropriately enhanced barrier precautions to help prevent the transmission of MDROs within the facility. And the last thing before I'm going to throw another question at you guys, is these are the organisms that it's important that basically we get the information on. If you look on the left-hand side of the screen here, these are the organisms that we just simply need routine reporting. So what does that mean? Essentially, we just need to know or be informed by electronic laboratory reporting to KDPH through the Kentucky Health Information Exchange within 5 business days of lab reports for these cases when they're identified. We do not need EPID 250s for all the pathogens on the left-hand side. We just need the lab reports. And like I said, you can take care of that simply by reporting to us electronically. The organisms on the right-hand side of the screens, the Candida auris, carbapenem-resistant Acetobacters, Enterobacteriales, and also the Pseudomonases, and also the Visa inversas, we need to have its dual reporting for that. We need an EPID 250 and also electronic laboratory reporting to KDPH through KHI within 1 business day. And so that kind of where these standards from as far as like the days and stuff like that, I want to make sure that you guys had your hands on some of the information in regards to that. So if you take a look at 902 KAR 2:020, that is the reportable disease surveillance regulation. And within that, if you, because we're talking about MDROs, if you go to sections 10 through 15, that specifically covers topics related to healthcare associated infections and antimicrobial use and issues with that. As far as what's required, when does it have to take place? And then they also basically, this particular regulation also talks about the EPID 250 form. So I just hit you guys upside the head with a lot of things, almost like machine gun fire. And I want to take a second to kind of find out and get some feedback from you guys. So I wonder if you could do me a favor. For those folks who basically are watching this online, if you could do me a favor, please scan the QR code in the upper left-hand corner of the screen. Or if you are following us on like your phone, or maybe you happen to be listening to this as you're driving or something like that, if you could, if you're driving, please have somebody else do this. I want to qualify that. But if you're not able to basically see this and you're only listening to this, you can go to slido.com, that's SLIDO.com, and enter the code 3474953. Let me repeat that. It's 3474953. And then please share with us what are the challenges that you happen to be facing as far as when you guys are reporting MDRO data to us. Oh my goodness gracious, we got somebody listening from Michigan. Well, that would be a challenge as far as reporting to us. I would acknowledge that. Okay. Gotcha. Good to know. I apologize. I'm sitting here reading as some of these things come across here. I'm going to comment on a few of them. Somebody mentioned knowing exactly what to report. I like a comment that was mentioned here, still manual. And I want to talk about that real quickly in regards to this, because it's not only, I hate to say this, but for a long time, it's been manual, not only for you guys basically filling out the EPID 250 form, and then obviously basically forwarding on to the reports onto us, typically in the past that have been coming to us by fax. But one of the other things is that we have to manually then take that information on the EPID 250 form and manually update it into our database. So if it pains you to fill out that form, believe me, it pains us as well, because we have just as much time basically to take that and add it to our database. And if we're basically having headaches and it's slowing us down, I can't even imagine like what it's doing for you guys' workflow. And so we felt like this really needs to change. And so just to let you know, I'm going to jump away from this particular slide, but please do me a favor. Keep adding the information to this. I'm going to gather all the comments that have basically added to this, and we're going to basically bring this back to the team and kind of like make sure any changes we do, we're implementing this as far as taking this into account when we basically tweak some of the things that we're considering to change the process. Okay. And so, like I said, one of the things that we want to do is we want to make it more efficient. We want to make sure it's accurate, and we really need to make it timely. If it's super onerous for folks at facilities to basically complete the information we need to be able to have a timely response back for any kind of potential things that maybe it's just a cluster, or maybe it's actually an outbreak that's going on, maybe not even at a facility, maybe it's going on in a region. That's just not really an efficient way to basically do that. And through the experiences that we had with COVID, that really came to light in a big hurry. And so we've been looking for ways to basically try and streamline this whole process. We really want to get the information as soon as possible in a way that basically makes it easy to analyze the information we're getting. We also want to turn around and get it back to you guys in a timely fashion so it's meaningful and you guys can be aware of what might be going on, not just at your facility, but in the immediate area of where your facilities are located. It's going to do a lot of things. Basically, if we can kind of make these changes on a good perspective, we can cut down on the burden that you guys are experiencing at your facilities and strengthen data sharing basically for providing or coming back with informed public health interventions. The other thing is this is going to save facilities money and basically save healthcare expenses if we can basically, like for instance, I'm just going to use this as an example. Let's say you're screening a particular patient or a facility that you had received the patient from had screened the patient before they left. And basically they basically send the sample out for testing. And now you've got this patient, or maybe you're hanging on to this patient waiting for the results. Well, if you don't get the answers back in a timely fashion, you got to keep this. You may be inclined to keep this person in some sort of transmission-based precautions until you get a result back. Well, if that whole process is slowed down, that's going to be a challenge. And basically that's going to be an increased cost that's going to be basically, that you guys are going to experience at the facility level, but also potentially the patients as well. And it's like, if we can do it better than that, let's do that. So another thing I want to find out is, how are you guys reporting to us? Like I said, back in the day, if people can still remember this, back pre-COVID, everything was faxed. Everything was faxed. And that was a very slow, laborious process, including if the fax machine ran out of paper. But that's another story for another day. If folks could do us a favor and please basically pass along here as far as how are you guys basically getting this information to us? And I'm just going to let this go. And now, yet again, and I think this might actually be the exact same code as before. There's a QR code up here on the screen in the upper left-hand corner. And if you are basically joining us from remote, or you're not able to basically watch this and you're in the middle of doing something else at work, you can go to slido.com again and basically enter the code 3474953. I believe that was the same one as before. And please share with us, there's going to be 3 options here as far as how you're getting the information to us. And so I'm just going to give this a little bit more time. We got some more folks basically adding information to this. So I'm seeing a trend with just the folks that have already basically gone on here. So I'm just going to throw a question at you. If there was a way, and Julia or Kristen or Chelsea or Melissa, I don't know if there's a way to do this, but I can't really see any kind of reactions. If you can let us know how many people basically, if there's a lot of people that raise their hands, I don't even know if there's a way to basically monitor that. But if there was a way we can get away from simply faxing the stuff to us, how many people would be excited?
We have multiple hands raised.
Okay, that's what I kind of thought. Yeah, it's kind of blowing up over here. Okay, so I have one more question for folks. So this is going to sound like an odd question, but I just bear your patience. It's the same code again, so that's good to know. How many Kentucky healthcare facilities are using direct data entry to report other reportable diseases to KDPH? I'm just going to let this kind of go here for just a little bit. I wish there was a way that I could basically throw in like real quickly another poll in here, but I don't have the capacity with the what I've got for the polling program here to do that. But I would really love to know, where are the settings. There's a number of folks that are doing direct data entry for reporting some of the other reportable diseases, and that's very interesting. We're up to, as you might imagine, there's a lot of people that maybe are a lot of locations and settings that may not necessarily be using this, but there's a sizable number, believe it or not, that are actually using that. We're currently at about 27% that are using it. But the overwhelming majority of 73% are not using it. But if there was a way that you could do it in a way, if you're already using it for some of the other reportable diseases, I'm curious to know, and folks don't have to necessarily like answer this right away, but I'd be very curious to know how many folks would be excited about the fact that if you basically, as opposed to having a whole nother pathway of getting this information to us, you just simply could just add the MDRO reporting using the format that you're already using. Would that be helpful? I have a sneaking suspicion this might be blowing up the chat over here. Oh, we've got more folks adding in here. Interesting. Okay. Well, continue adding comments there if you basically are at there. I'm going to sneak over to the next slide, but I really appreciate the input that you guys are providing. This is really, really helpful as far as any kind of direction that we may or may not want to go. But as folks can imagine, there is a big leaning towards going towards using electronic means to basically report cases of reportable disease, not only some of the ones that you may already be doing, but also using the same format to do this for MDROs. And so there's a lot of benefits for doing this. There could probably be an entire lecture talking about the benefits of doing this, but one of the things I did want to kind of highlight is that, you know, you can take a standard approach with this. The other thing is, which for some of our epidemiologists that work in the program here, if we can fully embrace this as a state, it makes it a whole lot easier to analyze the information that's coming into us in a timely fashion and be able to take a look at like the 1,000-foot, view or perspective on the thing to see if we've got an issue going on in a particular area, region, or whatever the case may be. We can also basically track how these particular pathogens are moving about the state, and being able to get that information back to you in a timely fashion, or to be able to basically respond to any kind of potential public health situation that might be going on, whether it's an outbreak or a cluster that's going on at a particular facility, or if there's a situation going on that maybe the facility may not necessarily know about it, but because of information that's coming to us from 3 or 4 different directions, we might actually be able to pick up on it first. We also want to make sure that this is a secure place where, we're doing it in a manner where this information is protected. and potentially be able to get, and this is a huge dream of ours, to be able to get real-time data so that we can analyze it. And that would be fantastic if we could do that. Obviously, for something like that, there's going to be a steep learning curve for folks if this is a whole new process. And so we also need to make sure that we're establishing channels to provide, basically, to get feedback and to provide feedback to facilities based on data quality trends, and to be able to have actionable insights from the data as far as things that are going on. And this is not just for the usual stuff that we basically get reports of. Maybe there's just odd situations that are going on that we could hurry up and get this information back to folks in a timely fashion so you could be on the lookout for some of these things. And so let's go on to the next one here. And there's, in addition to that, I've kind of beaten this dead horse as well, and that we're looking to try and have as accurate and timely data to be able to understand things that are going on across the state. We also want to make sure that we're being good stewards of the resources that we have available, not only at the state, but at the local level and at the facility level. And so for that, it's really important that basically we work together as a state. And I'm going to jump over here to the next slide real quick. And it's not only at healthcare facilities, it's also public health agencies. And by that, I mean local and state level, laboratories, clinical, public health, you name it. We want to have all of them working together in unison, basically, so we can get information to all the different players and stakeholders in an important, timely fashion. We also want to basically pull in healthcare professional organizations to help us with this. And most importantly, patients and the community. We need to pull in all these different perspectives to really get a good, clear understanding of what is going on. And more importantly, your role at the facility level is really, really important. And it starts essentially right now. We need to get feedback from you guys. We need to find out what is working with the current system, what's not working with the current system, the proposed changes that we happen to have. Is that really going to be an additional burden on you, or is this just an adjustment to what you're already basically doing? This is also going to allow us to basically advocate for resources here at the state. If we've got issues going on and we basically can get really good, almost real-time data basically to back up requests, we can really put in and defend the requests that we're making more easily if we could basically show that there's an obvious need for some of these resources. And then finally, basically, we really cannot be doing things like we did 5-10 years ago. We have to basically come into a more up-to-date process. I've read a lot of things as far as how public health agencies had received information from facilities and from basically clinics scattered throughout their jurisdiction. And, being completely dependent upon the old fax machine, this is 2025. There's a lot of better avenues to basically get the information and share it back and forth. And like I said, there's some really exciting ways to basically be able to take a look at this information and turn around and basically share this with applicable stakeholders at the local, state, and basically at the federal level to be able to defend what we need and be able to back it up with some robust information. That's a lot of things. There's a lot of highlights. I didn't give you a lot of specifics because we're still going through the process. One of the things we also want to make sure, and this is kind of like part of my wrap up, one of the things that we also want to make sure is that we're not providing you, multiple different ways that you have to report to us. We've already experienced when we had to do double reporting during COVID. You not only had to send stuff to the feds, but you also had to send stuff to us, and there was different forms that were used, that were required. Some forms were what the CDC required, some forms is what we required, and it just became, it wasn't a good use of our time in the midst of a pandemic. I think everybody can pretty much agree upon that. And when we basically came out of the pandemic and took a look at our own practices, there's definitely a better way to do things. And if we've got an opportunity to do it, we want to make sure that we're doing that. So I'm going to switch over here and kind of open things up a little bit. So I'm going to try and see if I can open up my little screen here so I can see feedback from folks here that are in the crowd. Let's see if I can do that. And does anybody have any questions? Like I said, I know it's just rough, broad brushstrokes that I had basically shared. We're trying to, so to give you guys a little bit more information, one of the things we're looking to try and do, we still need the information that's on the EPID 250. But if we can incorporate the EPID 250 into a reporting process that you guys are already using in some instances, like I said, it looked like, you know, almost just shy of like a third or a fourth of the folks that are basically in attendance here, they're already using some sort of electronic reporting as it is. If we can find a way to take that information, build it into a system where it's kind of like a one-stop shop for any kind of reporting across the state, isn't that like a sound idea for folks? Would people be really excited about that? And that's what we're trying to do. We don't want to create a whole nother avenue for folks to go down. You don't need another route. Is that a safe statement to make? I am seeing a bunch of yeses. Okay, so I don't have to twist anybody's arm. That's fantastic. Okay. I'm going to stop talking for a second. Yes, I would love to be able to give you guys a one-stop shop. That would be awesome. And like I said, not just for MDROs, for any reportable disease. That's what, and the good news is that's what we're trying to basically build here at KDPH as well. We are really, really trying to do that and make it in a way that you guys can slide it right into your workflow and for it not to be so disruptive. That's what we're shooting for. Now, obviously, the conversations that we have with folks at facilities, it's not just simply the initial EPID 250, and that's the only conversation we've got to have. Are there anyone at this particular presentation who would prefer to have less phone calls from our teammates? If there was a way to basically get all the information in a streamlined, easy fashion that is less disruptive than basically us interrupting you with a phone call, would that be okay? We've got a few yeses. We kind of figured that was going to be the case. And so that is something we're working on. So there's like if folks have seen a case report form that we might forward on to you, basically for the additional information about like how, like the different places that may have an exposure risk to identified pathogens that we've found, that have been, you guys have notified us about, and whether or not the previous facility has an exposure risk or anything like that, or usually it's like 3 or 4 places when you really get down to the whole investigation just within a couple of weeks with how much people move. We're trying to get that streamlined into a process. Literally, what if we could send you guys some sort of, like, as an example, like a QR code or a link to a particular web page, and you could go to a place where instead of writing out the stuff on a case report form or typing it out, you could just go to a online case report form where literally you got to find your information for your facility. Now, you may have to put in stuff specifically for like the patient's name, date of birth, and stuff like that. But even with the date of birth, what if you could just go to a calendar and pick your day as opposed to typing all that out? Would that make things a little faster? And then the other thing is, all the other stuff, it's literally, you have to just basically find whatever the pathogen is and click. as opposed to writing things out. You pick out the pathogen, you pick out the particular carbapenemase that was identified, if that happens to be the case, or in the case of Candida auris, you just find Candida auris, click, go. All the information for the facilities across the state will be uploaded into this case report form, so you don't even have to type out the name of your facility. Click it. That's it. How would that make you feel? Would that cut down on some of the work that you got to do? Now, we still need that extra little bit of information. I acknowledge that. But if we could do it in a way that's less painful for you guys, and so we get information back to you in a timely fashion, if we could put that into an information system that we can analyze right away, instead of us having to manually take that information and put it into another system, that's the route that we're going. So, okay. So I'm trying to be mindful of my time here. I've been doing a lot of talking. Does anybody have a question for me?
Michael,
are we out of time?
No, there was a question.
Gotcha.
If tested and resulted at a hospital lab, who is responsible for reporting? A hospital or skilled nursing facility?
I'm going to answer it this way. Generally, 9 times out of 10, the skilled nursing facility is going to know the information as far as like the epi information with that, because they're not really going to be a patient of the hospital. So we may have to lean on the skilled nursing facility to provide some of that information that we're going to need. I'm assuming basically like the normal workflow that would be reported to the skilled nursing facility. So I believe the onus would be on the skilled nursing facility in this particular example to report this. Was there, I'm going to scroll up here if there was another question hiding in the chat. Hospital completes labs, but do not complete cultures when indicated. Tanya, I saw your comment in here. Is there a way you could elaborate on that so I have a better understanding of what you're asking real quick? Are you talking about as far as like it should reflex to a culture after like the initial test?
It said culture test.
Right. Complete the labs, do not complete cultures when indicated. So they're just not even doing the cultures based on what's going on with the. Okay, so are they like, as an example, let me see if I'm understanding your question. Tanya, is it safe to assume that you're possibly working in a long-term care facility? Okay. So essentially they're doing like a UA and then they don't do a culture to go along with it. Is that kind of what I'm sensing here? Just as an example, if we're talking about like some sort of potential like urinary tract issue, is that what I'm sensing? That could be frustrating. I am going to forward that on to our folks. Indicated at culture to be done, but they do not complete one. Oh. Okay. I'm going to pass that along, see if we can get some follow-up for you. Okay, Tanya? Tanya, I tell you what, if you could do me a favor, if you could, either one of you, either yourself or Allison, if you could do me a favor, if you could reach out to me, my contact information was going to come right here at the very, very end of the presentation. We may want some additional information, just that we're talking apples to apples here. If you could do me a favor and do that, I'd greatly appreciate it, okay? And we'll make sure that you get timely follow-up and a clear answer from our perspective, okay? I want to make sure that doesn't slip through the holes on that, okay? Because another thing we want to do is we also want to make sure that we're also good stewards of our resources when it comes to tests too, and make sure that we're doing it at an appropriate time. We want to make sure that maybe there's a particular reason why they didn't do that and just simply didn't reflex to a culture. I don't know the particulars of it, but I want to make sure that we're not jumping the gun and giving an answer that's not appropriate for that particular time. Also, the other thing is we don't provide clinical advice We are just providing public health advice when it comes to, or recommendations when it comes to our interaction with our clinical friends. So there's my caveat, but I would really appreciate getting follow-up from you guys so that we could basically, okay, Jill, I'm going to be completely transparent with you. Way back in the early days of COVID, myself and my colleague Chad, who was with the program, we were intimately entwined in the COVID response, and our regional IPs have kind of taken that over. I need to follow up with you on that. I do not have a current answer. I'll be completely honest with you. I've been pulled into other duties and I have not had my fingers on reporting of COVID cases. And so I'm just going to be honest with you. I don't have a clear answer for you. Kimberly, we get residents from the hospital antibiotics with vague diagnosis and no cultures are sent with them. That's frustrating, especially if you've got pending cultures, or if you've got it's one thing if they're on antibiotics, but like how much longer is left on that? We don't need to basically be repeating stuff. That is frustrating. I would agree with you. If there was a way to basically, and that's one of the things we've recommended with some of the what was I going to say? The template for interfacility communication. On the bottom of it, it's got as far as like ongoing pending cultures, current antibiotics, and length of duration that they have still remaining on those doses. That would be really, really important for basically that to be shared with the receiving facility as well. Like I said, yet again, so we're not duplicating efforts. Or it will take 5 to 7 days to receive. Yes. Unfortunately, what Pasha, I'm just going to pass along one of the things that's also very unfortunate is some of these cultures, and with the experience that I've had with Candida auris, it has been very, very frustrating. It's those cultures can take forever to finalize. That is very frustrating. Oh, Reba, that's unfortunate. She had shared that basically we had a clinic that obtained UA with no culture and sensitivity. When I called the doctor's office, was told that they went by the last culture and sensitivity that had been done. I'm just going to let that stand there.
Michael, I did get one question. So
Sure.
there was a comment in the Q&A. It was they're told the hospital would report it and not us at the long-term care facility. I'm assuming that that's the test results. And I think it's going to be dependent upon whether or not the test was done as a send out from long-term care versus
Yes.
the patient being admitted and the test coming back positive. So you may just want to confirm the how the specimen arrived at the lab, because some labs will do outpatient testing and some do not. So I think
Right.
that that is something to potentially follow up with the facility that received that specimen and how that specimen physically got to the lab. There was also a question that somebody had about whether or not they said they were faxing. Is that a problem? Are they not to fax anymore?
No. So thank you very much. It's not a problem. Unfortunately, we're really trying to encourage facilities to move to more of an electronic form. We're still receiving the faxes. And in some cases, facilities, that is the capability that they have. There's no way to work around the infrastructure that they happen to have and the capabilities of the facility. And there's not much that we can do about that. However, if there is a way to switch over to electronic reporting, we're encouraging folks to basically to be onboarded to be able to do that. That we would really appreciate that, because like I said, of all the added benefit to not only response from our perspective, but also being able to share the information back if it's a regional concern. It gets to us a whole lot faster if it's just basically like a direct data entry, or feed directly through KHI, just as an example. several of our folks within our team could, and also there's a whole team dedicated at KDPH to help facilities to basically get onboarded with the different electronic reporting platforms that are available. And so we could definitely put them in touch with this team of liaisons to help basically facilitate that whole process. Yes. So Allison, I think the two of us were thinking the same thing at the same time. We could put you in touch with basically so the team that basically we have here within KDPH that's helping facilities basically to be onboarded with that. So there's a comment in here for folks who are not able to see the chat. In Nevada, our CRS cases are high in my skilled nursing facility. I have 40 residents in a 98-bed facility with CRS. Ooh, and a crab CROs. Our problem here is hospitals are not relaying information. I happen to see it in a note somewhere. I'm hoping one day there's a CRS portal where we can just simply look at it to verify. Any news on that if it is a thing? My health department said it was being talked about. So unfortunately, I don't have any good news for you basically in Nevada. Or Jessica, did you move from Nevada, or you listening to us and working in Nevada? Can you clarify that real quick? Because I don't want to misspeak here with my answer to your question real quick. Just kind of dropping a little comment in here in the chat real quick.
Hey, Michael, we have a lot of folks from out of state. So you may see, we actually have 28 states represented. So I'm assuming that she is actually from Nevada.
Okay. So Jessica, what I can answer you is that yes, I am. Okay, fair enough. Interestingly enough, we do have a process in here. It's an XDR registry. That was the formal name, and then it changed to ARI, and now it's the Andrea project. And please don't ask me to explain what the acronym stands for. I'm not going to be able to do justice to that. But we are test piloting a particular process where if you're at a particular facility and you're admitting a patient and you want to, one of the things that we would like to be able to do is when you admit them, the ADT, the admit, discharge, and transfer system will basically send a communication directly to KHI, which is the Kentucky Health Information Exchange, about that new admission. And so any pertinent information, like if they had a previous result of an MDRO of concern, that information could be relayed to your facility that's admitting that patient right away, and you'd end up getting a red flag in your chart. That's what the goal is. So it's not like you don't have to necessarily even go and do a search. The goal is that when you're admitting this patient and logging them in as an admit to your facility, shortly thereafter, you'll get an immediate flag saying, hey, by the way, and they're not going to be able to give you the exact details, but just you have a recent history of pathogen XYZ, okay? And you could reach out to the state health department to get some more additional information as far as what the red flag's all about, but at least to give you a flag so you know you need to put them in some sort of transmission-based precaution. We're working on that actively. We are in the process of piloting that in a particular region so we can work out all the bugs. There's no point in us rolling it across the state with a whole bunch of issues and challenges of the process. We're trying to get rid of all those problems ahead of time before we roll it out across the state. So we're currently, as you can imagine, having issues with the signaling back and forth communication electronically, and we're trying to debug that process first. But stay tuned. We're a lot further than we've ever been with that particular process, and we're really excited about it, but got to work through all the bugs that are in that process. But yes, that would be a fantastic way to let folks know already that this particular patient that you're admitting already has a recent history of something that requires transmission-based precaution. And then we could just simply follow up with the additional specific information. But and yes, I did read Terry's comment in here for folks that basically have these like particular charting system or electronic health records. Sometimes you can basically see information through what is it? Care Everywhere for Epic, I believe, and there may be another name for another thing for one of the other charting systems. And no, I'm not promoting a particular charting system. I'm just saying they're the big player on the stage these days. But yeah, it makes it a little bit easier to see stuff on, and that sort of interconnectedness is really kind of the nice thing. If we could get to something like that, where just a quick little query and you could get the information that you need right away in a timely fashion, that would be ideal. Yes, one of the frustrating things, Mike, I'm reading a comment that you had shared. It said, we understand that and struggle with communication from hospitals as well. By the way, it's not just from hospitals, it's just any time that you're moving a patient from one location to another, sometimes some of the information kind of it drops into some of the gaps in the communication process. And unfortunately, after you've admitted or received this particular patient, it might be some time before you can actually get the pertinent information you really, really need to basically make sure that you don't accidentally transmit some of these pathogens of concern amongst their neighboring patients. Okay. And by the way, for clear transparency, I used to be a bedside nurse, and I think everybody can relate to, if you've worked at the bedside before. I call it War and Peace that you receive in the manila envelope, which is all of their stuff from the previous facility. That is sometimes very difficult to move through, and you really want to have something that's easy to access, quick little bullet points of information, so you know what things you need to do right now in a time and fashion, and then you can go into the minutia later on. But you need to have some of the things right at the foreground as soon as possible. And using that interfacility communication tool is really, really helpful in whatever iteration it is, as long as it's readily available to a person taking a quick look at that chart. That would be really handy. And so we're really encouraging facilities to adopt that type of process too. How are we doing on time there, Julia? I think I'm getting down to just a couple minutes left, if I'm not mistaken, right?
That is correct, yes.
Okay, so I tell you what, let's kind of jump to a couple other things here real quickly. Let me get back to, where is my control panel for the overview. Let's see if I can just do this. Nope. Okay, I got to find this little control panel. Hang on just a second, real quick. There, nope, that's not it. Bear with me just a second. I apologize. And so some of the information that's been presented here. Here are some references for you guys to be able to get some additional information. There's a lot here, but when you guys get the slides, these are all active hyperlinks, so you don't have to basically type all this stuff out. I'm a big fan of having hyperlinks already there instead of just the whole thing that you have to type in the computer. But if anybody has any questions, here is my contact information. Please, there was a couple of folks, I apologize, I just totally minimized some of the folks from the chat that I was having a conversation with. Please reach out to me with your contact information. The two that were asking about the things, as far as the question about, I think, like UA and then switching over to a reflex culture, if you don't mind just simply reaching out to me, I'd greatly appreciate it. I just want to make sure that whatever final answer I give you, that I'm giving you correct and complete information. And I don't want to jump the gun. Just, there might actually be a legitimate reason behind some of that based on what's going on. So then again, there may not be, who knows? So, okay. Let me go see if there was something else that somebody was trying to share with me. But I mean, other than that, all right. And that's pretty much what I've got, Julia.
All right. Well, thank you very much, Michael. Very great information. And I think everyone would be excited if we were able to streamline that process. So thank you. Thank you.